am Major Retired André Thivierge, and I am the co-chair of the Ottawa Veterans Task Force. I am happy to bring this initiative to you in partnership with the Department of Family Medicine at the University of Ottawa. In this episode, we will be exploring the unique aspect of physical medicine and mental health in the veteran population. We will examine the different forms of psychiatric disorders such as PTSD, alcohol, substance abuse, and other addictions such as video games. We will also explore the challenges experienced by veterans with chronic pain and the pharmacology to observe should your patient have this comorbidity. Our guest speakers today are looking forward to sharing with you their wide range of experience and expertise in providing healthcare and well-being services to our veterans and their families. Thank you and enjoy today's episode.
I'm Brent Wolfrom. I'm a family physician currently at Queen's University in Kingston, Ontario, and previously was a member of the Canadian Armed Forces Regular Force, and now I'm a member of the Reserves. I have a particular interest in veterans' health and the care of soldiers' families.
Hi, my name is Lieutenant Colonel Markus Besemann. I'm still the Chief of Physical Medicine and Rehabilitation for the Canadian Armed Forces. I've got 6 months till CRA 60, and transitioning involves opening a veterans clinic in Ottawa called Beechwood Physical Medicine. So that's part of the reason why you see me sometimes as Lieutenant Colonel, sometimes as Doctor.
Markus, can you just elaborate on your journey as a physiatrist and a medical officer to your current practice and your clinic that you're starting in Ottawa?
Absolutely. Thanks so much, Brent. It's an honor. So I started way back in '86 as a second-year med student, going to the recruit center in Hull when there still was one, and was a GDMO for 4 years in multiple different locations. Thoroughly enjoyed what I did, but I realized how ill-prepared I was for the combination of physical and psychological pain that I was seeing as a GDMO, and decided in '93 to go back to do physiatry. In that era, we were cutting back in the CF, and so I had to decide between going to Gallenkirchen or Villar or one of those famous postings in Europe, or to go back to do physical medicine rehab on my own. And it was a tough decision. I cried, to be honest, leaving the forces, but I went back, became the Chief of Rehab Medicine in Hull for about a dozen years, which was a huge learning experience. And in 2008, the CF called me back when we had all these folks coming back from Afghanistan with severe musculoskeletal and other injuries. And now, as I'm reaching 60, time is flying by fast. I'm heading out on my next venture, which is opening a multidisciplinary physical medicine clinic, which integrates the best of physical medicine with mental health, as I think the two are basically tied together more often than not.
Thanks, Markus. Certainly that's what we're seeing in a lot of literature as well, that there's certainly a relationship between chronic physical complaints or chronic pain and mental illness, particularly amongst veterans. What would you see as some of the unique aspects of treating veterans in your current practice?
So if I had to summarize the vast majority of people I see now, that obviously doesn't encompass everyone. Sometimes it's nice to see just a simple single joint issue that can respond to a simple intervention. But I have to say those simple textbook cases are becoming fewer and far between. Maybe as a specialist, that's the way it should be, that we should leave those cases to the frontline healthcare practitioners. But the polytrauma triad has been well described, both in civilian and military literature, but mostly in military literature. And as you all know, most of our folks have had some degree of traumatic brain injury. They have chronic physical pain, and they have some mental health diagnosis. So either PTSD, chronic depression, anxiety, which is obviously rampant in civilian society as well. And I tend to call it a polytrauma tetrad, because in my population, the fourth dimension of this, which is critical, I think, for everyone to understand, is adverse childhood events. And precisely those, because they lead the member to decide to join the forces in the first place. In other words, that young protector that was born at a very young age and knew they wanted to put the uniform on to make the world a better place was born out of carnage. And I hate to say that, but this is just the reality we contend with. And often when patients present with that catastrophic event, or even sometimes a minor event, it's not just the seminal event that's at stake here. It's all the preceding stuff that happened well before they put the uniform on. So I know that's an earful, but that's kind of the gist of patients I see. The beauty of it is when you address it in a holistic fashion, the satisfaction from a clinician's perspective, I find really increases my joy in practicing medicine.
I want to pick up on that, Markus. I think we often think about PTSD and physical injuries and that linkage as being really entirely service related amongst veterans. And you're suggesting that likely there's a predisposition related to adverse childhood experiences, which I guess isn't surprising. Do you have any advice for family physicians in particular caring for veterans who are experiencing chronic pain?
So the first one I would say is authenticity above all else. I think often what I see is that civilian clinicians, for better or worse, especially when they're dealing with people that have done some pretty amazing things, I see a lot of special forces operators in my practice. And to be totally honest, they can be intimidating at first because these are almost superhuman beings. And yet when you see underneath that superhuman being a hurt little child, and if you just drop the armor that we all wear as clinicians and be authentic, then they also drop their armor. And I think soldiers are the biggest bullshit detectors out there from my perspective. And if you drop your armor, they will quickly drop theirs and let you know what's really going on. If you come across as inauthentic or putting on a show or trying to impress them, that's not going to fly, because let's face it, there's not much to impress when you deal with somebody who has lived on the razor's edge. And the last thing I would say is allow yourself to be human. So in other words, if that story that they're telling you becomes overwhelming for you, and I've often told patients this, and my heart is beating, the time out that we allow our patients, allow that for yourself, because you might be the first clinician that they've seen that says, could we just pause for a second? Because what you just said has really triggered me. And that sounds selfish as a clinician, but I think it's the biggest rapport you can build with your patient, because nobody probably acknowledged that until you did. And then that authenticity hopefully will build a bridge that will lead to getting to the root cause of the problem.
Do you think it's important that we specifically address the issue of adverse childhood events? So should we be screening for adverse childhood events, for instance, in our veteran patients?
That's a great question, and I would leave that to my esteemed colleague, Lieutenant Colonel Tuka, to maybe address. But I posed that question. I gave a talk at the International Congress of Military Medicine in Brussels recently. It was their 100th anniversary. And I asked that specific question. There are some very eminent British researchers who've looked at that. And clearly we know that it's predictive, but screening for it hasn't shown benefit in the sense that what are you tangibly going to do about it? Are you going to prevent someone from deploying? Are you going to put them in a different boot camp? I think if anything, it's being sensitized to it. Early on, if we did have a recognition system that some of the trainers and the leaders would recognize certain seminal features of people that have had these types of events, that we could potentially offer them help before the crisis occurred. But outside of that, I don't think that mass screening, from what I've seen, has necessarily borne fruit, even though we would wish it would.
Do you recommend any specific resources for physicians caring for veteran patients?
So I've got a whole bunch, but if there are a few that I would strongly recommend, there would be works by Dr. Gabor Mate, who's written a brilliant book called When the Body Says No. And patients that I've seen in the military resonate with this because their bodies have been saying no for a long time. And they've been on sort of master switch override in that they've been taught to override the signals their bodies are giving them. And so if that's the only truth in our whole existence is the signals our bodies are giving us, and these patients have been taught to override it, it's no surprise that when pain hits the runway, so to speak, and it's now unmistakable as a signal that something is wrong, that it would be out of proportion sometimes to what we might expect for a given situation. So certainly when the body says no, the mind-body prescription by Dr. John Sarno that Dr. Gabor Mate refers to often, and Dr. Alan Abbas, one of our Canadian psychiatrists who was a former GP and saw all these psychophysiologic disorders, which again usually had a bad connotation. And he has a beautiful way in the book called Hidden from View of describing how a family physician can approach these psychophysiologic disorders in a very, how should I say, authentic and compassionate way. I've done the Compassion Inquiry course, which I would encourage any physician to do. And it does focus on that compassionate piece that we all need to be when we get to the root cause. And just in summary, I would add the three letters that I use in terms of what matters most in rehabilitating soldiers is IBM. It's an easy thing to remember: identity, belonging, and meaning. And those three, if you can remember that. So every soldier wonders who they are once their body's no longer doing what it's supposed to be doing. They need to belong to a tribe. And that's another book that every GP needs to read, is the book on tribe. And meaning, what does all this mean in the greater context of my life?
Markus, family physicians often feel a bit frustrated in treating chronic pain. It's a very tricky thing for us to adequately treat. Do you have any advice for us in how to treat chronic pain in general, or specifically amongst veteran patients?
I would say the biggest piece is that we categorize pain, in a very broad brushstroke perspective as nociceptive, neuropathic, and neuroplastic, or nociplastic. And those are the three levels that we generally look at. Now, the problem with chronic pain is that we treat it like an acute illness, and that we look for where the broken piece is, and we're trying to fix it, or we get imaging that shows us something that a surgeon could potentially fix. But what if that's not where the problem is? So our first line of defense is making sure there are no nasties there, and every protocol about red flags tells you that. But then further up, are there other reasons why this pain might have been modulated over time? And that's where the mental health pieces and the previous experiences and so forth come in. So yes, always do due diligence as a physician to rule out the red flags. Once that's been ruled out, don't dig too far down, although the patients, specifically military patients, will compel you to keep asking for more investigations because they're very Cartesian in the way they look at their bodies. And the biggest thing about educating them is just to say, look, the mind and body are not two separate entities.
I like that. The mind and body are not two separate entities. I'm gonna use that. Thank you very much, Dr. Besemann.
Thank you.
So my name is Dr. Andrea Tuka. I am also a Lieutenant Colonel. I am the Chief Psychiatrist of the Canadian Forces.
Andrea, can you comment on the unique aspects of mental health related issues or concerns amongst serving soldiers?
Yes, so mental disorders are prevalent and impactful in military organizations, and the Canadian Armed Forces is not an exception. The specific military service-related stressors, such as increased risk to exposure to traumatic events, frequent postings, which disrupts family life, often being away from home on training, courses, exercises, different taskings, all can take a toll on service members' well-being. We know that during military service, members are deployed to participate in wars, peacekeeping missions, counter-terrorist attacks, or humanitarian or disaster relief activities, which carry a high risk to experience traumatic events and not uncommonly multiple traumatic events. The extent of exposure, the length of the deployment, the time between the deployments, and the repeated deployments are all established as risk factors for developing post-traumatic stress disorder and other mental disorders. And furthermore, the nature of the traumatic events experienced on deployments can frequently challenge fundamental beliefs about the self, the world, and humanity, which can lead to moral distress or moral injury. And Markus talked about as well that we have to keep in mind that military recruits have increased rates of childhood physical abuse, sexual abuse, and neglect, as well as high rates of family disruptions compared to the community averages. And these factors have been found by multiple researchers to be salient in the development of post-traumatic stress disorder and other mental disorders. I would like to add as well that in terms of help seeking, military service members might have difficulties to seek help and engaged with treatment. Obviously, many of them worry about potential career implications of health-seeking behaviors, And also they can see seeking help to be opposed to the warrior ethos, which is inherent to military culture, which emphasizes the self-reliance and strength, resilience when responding to adversity.
The topic of comorbid mental and physical conditions amongst veterans has come up a few times through this series. Can you comment on how the Canadian Armed Forces manages that interplay between mental and physical health concerns?
Yeah, Markus talked about much more in the details how to manage them. What I would like to emphasize or highlight is that we use in the Canadian Armed Forces, we use a patient-partnered, multidisciplinary approach to address the mental health-related problems and treat mental disorders. Our multidisciplinary mental health teams include psychiatrists, clinical psychologists, social workers, mental health nurses, and addiction counselors. We also have mental health chaplains who can address spiritual issues. We also utilize, besides the physiatrists, occupational therapists who are familiar with mental health issues, and they can be very, very helpful in the treatment of specifically significant functional impact related to the mental disorders. And we also in mental health services work close collaboration with primary care providers to optimize the integrative and holistic approaches. We also involved families in the assessment process, as well as in the development of the treatment plan, and able to provide couples counseling or family therapy if needed. We also regularly schedule interdisciplinary case reviews and case conferences involving the chain of command as well, to facilitate individually tailored and timely gradual return to work. We primarily use evidence-based treatment modalities, relying on the relevant up-to-date clinical practice guidelines, but we also apply complementary alternative treatments in certain cases.
The Canadian Armed Forces clearly has a very robust system in place and is quite a bit further ahead of the civilian system with respect to patients' medical home and interdisciplinary care. Do you have any advice for physicians caring for veterans who don't have access to all of those rich resources?
So yeah, we realize that the care will be different for veterans after they leave the Canadian Armed Forces, and I think our soldiers are aware of that as well. So my advice would be to family physicians who care about veterans is to first of all to show genuine interest and learn about the veterans' military service, which will help establish rapport and trust with the patient. Asking about the length of the military service, the trade the veteran worked while they served, and the overall experience of the military service would be helpful to understand. Obviously, ask about the deployment experiences, where and when the veteran was deployed, how did the deployment impact the veteran, as well as how did the deployment impact the family. We know that being deployed even to a war zone does not mean that the veteran had or have post-traumatic stress disorder or any mental disorder. In fact, I am happy to say that the majority of the service members are doing well after deployment. Also ask how the veteran did release from the Canadian Armed Forces. Was it a voluntary release or it was a medical release? When members released from the Canadian Armed Forces based on mental health condition or mental health conditions, or even the combination of physical or mental problems, they usually have been receiving care at least for 2 years prior to the release date. So members are released when their mental health conditions and physical conditions as well are stabilized, and most of the time family physicians will be able to manage the veterans' medication regime after release, and the veterans can continue seeing the psychologist or therapist for psychotherapy, what we highly recommend, at least until they settle in their new life as a veteran. If veterans move to a different location, a new psychologist or therapist will be arranged for them before the release. And in case the member needs psychiatric care, referrals to the regional operational stress injury clinics can be made, where they can access multidisciplinary care similar to what they experienced in the Canadian Armed Forces. Also, I would advise to be aware of the veteran stress source around and after the transition. For example, the loss of identity, the difficulties about seeking new employment, financial strains, trying to integrate into the new community, finding new social connections, and so on. Members, as I mentioned, usually settle in their new life as a veteran after a year. And around the time of the transition, the signs and symptoms of depression, anxiety, or even post-traumatic stress disorder can flare up. And also be aware that around the time of Remembrance Day or the time around the anniversary of the loss of their comrades can be specifically difficult for veterans, which can lead to flare up of these symptoms.
Do you recommend any specific resources for physicians caring for veterans?
Yes, there are actually a number of resources available for family physicians to know about military mental health. I recommend to be familiar with the relevant updated clinical practice guidelines. I would highlight the U.S. Veteran Affairs Department of Defense clinical practice guidelines, which are published on PTSD, major depressive disorder, substance use disorder, and suicidal behaviors. Those are the relevant mental health related clinical practice guidelines. And those addressing specific issues to serving military members and veterans. Also, they have a condensed summary format, very easy to use, easy to read by primary care clinicians. And also they come with educational materials for patients and families. The Australian PTSD guideline is also an excellent resource, similarly addressing the veteran population with special guidance for patients and families. The National Center for PTSD website have plenty of information for medical care givers, patients and families in the forms of videos and written materials. Veteran Affairs of Canada developed the PTSD Coach and Operational Stress Injury Connect mobile applications. These are very useful applications which provide education, information on operational stress injury and PTSD-related signs and symptoms. And they can be used as self-management tools, and they can also help to monitor the progress of the treatment the veterans are receiving. In terms of services, I mentioned the most important is to be familiar with the local, regional operational stress injury clinic where veterans can receive multidisciplinary care. I would also highlight the peer support network programs, the Operational Stress Injury Social Support, the OSIS program, which provide an active listening through regular group meetings, as well as they offer family programs. There are other peer support and advocacy organizations and programs such as the Wounded Warrior and Soldier On program. I collected all of this information in a slide, what you can see.
Thank you very much, Lieutenant Colonel Tuka. I want to thank Dr. Besemann and Lieutenant Colonel Tuka for joining us for this podcast. Certainly we're hearing a lot of consistent messaging around the interplay between physical and mental illness amongst veterans, the importance of adverse childhood events, and the increased incidence of adverse childhood events amongst the serving soldier and veteran population. We've talked previously around military culture and that importance of bridging that gap between our Western civilian healthcare culture and the military culture. And I think Dr. Besemann's comments around that authenticity and vulnerability is really critical in caring for our veterans. So thank you for that reminder, Dr. Besemann.